Thank you so much, Roxana. Thank you so much for the introduction, and thank you so much for inviting me here today. It's been 3 years since I've been back in New York. The last time I was meant to come, we suddenly had the pandemic, and so it's fantastic to be back. When I looked at the title of this talk, I realized that this was going to be more than just a kind of academic journey through FFR, but a kind of personal journey, because I trained in one of the centres in the UK, Imperial College London, where we developed IFR technology, where physiology has been the absolute backbone to what we do in our cath labs. And I've realized that over time, things have slightly changed for me. So here are my disclosures. Sorry. Okay, cool. Here are my disclosures. So I looked back and started thinking about the data, and realized that when I trained back in Imperial College, I feel very old now, that there really was a good old days. There was a moment when everything seemed crystal clear in terms of invasive physiology. We knew exactly what we were doing, and we thought we were doing exactly the right thing for patients all the time. We had lots and lots of data out there that we believed, and we were happy to use in the treatment of our patients. The vast majority of the data started with us thinking that ischemia was incredibly important for patients, and that in those patients with high burdens of ischemia, based on observational data, there were higher death rates and MI rates, and that ischemia and a reduction in the blood supply to the heart was really important to our patients. We knew that there was lots of data out there from FFR that told us that actually it was possible to defer patients who had low ischemic burdens, that they did very well in the short term, and even in the long-term data out to 15 years, those patients did better. So we didn't need to stent everything we saw. We could use FFR as an evaluation of what was best to stent, and then we could happily be safe with the fact that if we deferred patients, they would be fine. We also knew that if we used FFR versus angiography based on the FAME data, that we had better major adverse event rates, and that patients did much better. So all of this seemed very clear, and this was why we were using physiology all the time in our cath labs. We had data from FAME2 that showed that while using FFR in stable patients didn't necessarily reduce death or MI rates, it certainly reduced the risk of urgent revascularization, and this seemed important to us. And all of this we put together in terms of working out what to do. We also had lots of data that showed us that the use of physiology frequently changed our treatment strategy. We could take 3-vessel disease down to 2-vessel disease, 1-vessel disease back up to 3-vessel disease, but placing an invasive physiological wire down a vessel meant that we could understand much more about the physiological pattern of disease and decide on that basis exactly what to do. So it all seemed totally clear. We knew what we needed to do, and importantly, when we stented patients, the FFR and the IFR would go up in patients. We could see that the burden of ischemia was reduced, and of course, we had that belief that ischemia was incredibly important to patients. If we improve the blood supply to the heart, they should do better in terms of their outcomes. And importantly, because I believe this isn't really just an FFR talk, it's an invasive physiology talk in general, we also had the data that, of course, my group at Imperial and my PhD supervisor, Justin Davies, pioneered, which showed us that IFR was non-inferior to FFR in terms of guiding treatment strategies for PCI. So we could use all of those invasive techniques interchangeably. In the SE guidelines, we were given a 1A recommendation for both FFR and IFR, and of course, in our labs, we rolled it out. And actually, in our lab in Imperial, we use invasive physiology in around 80 to 90% of cases. We used it in a very black and white way. We were happy to say that there was a red light if the FFR or IFR were negative, and we shouldn't do anything further. And we used the green light of FFRs of less than or equal to 0.80, or IFRs of less than or equal to 0.89 to tell us to treat. And we were happy to use these very binary cut points. But now I'm coming to where we are now. It all got very, very, very tangled. So that very clear, good old days where we were happy to use these binary cut points kind of got messed up over time with lots and lots of data sets, including data that I helped to produce. And now it's become a bit more confusing. I started to look back at the data and think about the data in a less black and white way. So let's look back at some of that physiological data, and you can go on that personal journey with me. So first, we were very happy to believe that if we performed physiologically guided PCI, we could improve angina. But of course, all of those trials that we had before were unblinded, and patients were told exactly what they'd had done, and perhaps that had had an impact on what happened. We saw from the FAME dataset that, in fact, if we used FFR versus angiography in terms of guiding treatment, there was actually no difference in terms of functional status. So while we might have believed that improving the blood supply to the heart definitely would improve angina outcomes, the data wasn't so clear. We also looked back at the FAME2 dataset and thought about that urgent revascularization trigger and thought about it much more clearly. Now, you can imagine what happens in an unblinded trial when you tell a patient that you've passed the pressure wire down their lesion and you fixed it with the stent. The blood supply to the heart is much better. They immediately feel better. What about if you tell them that you've used this new pressure wire to assess the lesion, we've worked out that the lesion really is significant and the blood supply to the heart has been reduced, but we're not going to do anything further because you're in a randomized controlled trial. What happens next? Well, patients come back with chest pain. They come back with chest pain immediately after they've been told that they were not stented. So when you look back at that FAME2 data set, not with my initial very naive eyes, you start to think about it more clearly and realize that actually trial designs can have a real impact on what happens next. So many of those patients that came back in the FAME2 trial had symptom-only chest pain, no troponin elevation or ECG changes, and they were predominantly in the medical therapy group. So perhaps that unblinded trial design had really had an impact on the results. And importantly, it doesn't seem to have had as much of an impact on patients who came back with true acute coronary syndrome events. So maybe some of that data that we took to really guide where we were with physiology needed to be looked at more closely. How about if we looked at the benefit of PCI in terms of a continuum of ischemia? Well, we have the sense that the lower your FFR or IFR, the higher your ischemic burden, the worse you will do, and there are lots of meta-analyses out there that show that. But in fact, many of these meta-analyses are driven by those urgent revascularization rates in trials like FAME2. So we need to remember that while it feels that the biological plausibility is there, that actually perhaps the data doesn't support this. And it started to get even messier as we got the results of ischemia that showed us that that original association that we had between ischemia and outcomes in observational data sets was not so clear in the randomized control trial. And in fact, as we've heard from Professor Shaw today, that the anatomical trigger of events seems to be more obvious. And then we come to some of my own data. We started to look at what happens if we try and predict the placebo-controlled impact of angioplasty on angina. So we remove that element of unblinding that might change the event profile in a trial and take a blinded trial to try and work out what we should do. Well, what we saw was that if patients had lower FFRs and IFRs, higher ischemic burdens, we were much more likely to see an improvement in ischemia on a stress echo with angioplasty versus a placebo procedure. And importantly, that we did see that 20% more patients in the angioplasty arm were free from angina. However, we didn't find a signal that lower FFR or IFR rates predicted the improvement in angina. Now, this may have been because the trial was underpowered to do this. It may have been because there's much more to study. And now we come to the two trials that really over the last year have started to confuse us even further. We were hoping from Flower MI that we could really use FFR to guide what we did in non-culprit intervention in patients who'd come in with ST elevation MI. But in fact, we found that FFR-guided angioplasty in the non-culprit lesion versus angiography-guided PCI, there was no difference in outcomes and it was non-inferior. So again, that absolute panacea of FFR seemed to be suddenly challenged. And in data from the UK, we started to understand that actually systematic physiological assessment of all lesions at a diagnostic angiogram doesn't necessarily have an impact on what we do. It doesn't reduce costs, and it doesn't necessarily improve quality of life in patients. So while we were using physiology to 80 to 90% of our diagnostic caths at Imperial, we started to wonder whether we should really be doing that based on the data from RIPCORD 2. And finally, we've got FAME3. FAME3 that confused us even further because we were hoping as interventionists that we could use FFR to really improve outcomes in PCI patients versus CABG. But actually, it turns out that when you take very, very complex patients, their outcomes don't necessarily improve just because we've used physiology. The complexity of their disease means that PCI is non-inferior to CABG. So where are we now? Where do we even go with this massive myriad of things that have made us really start to question what we should do? So I think we need to be really, really realistic. We need to understand that there's a reality of ischemia, that there is no ability to use a binary cut point to decide exactly what we do, and we need to use much more than just the physiological assessment to guide our treatment strategy. It is likely, and we hope, that with the higher burdens of ischemia, we are more likely to have an impact if we intervene, but we've got to get more data. What we also need to understand is that physiology gives us much more than just a binary cut point or a red light, green light, go, no go situation. It actually allows us to think about the pattern of disease. It tells us about whether we have diffuse or focal disease or a mixed pattern. And in fact, over time, I think we're going to realize that it's this that makes an impact to treatment. We know that even after very good angiographically successful PCI, there is residual ischemia in up to 25% of patients. And it's possible that this is the problem. We also know from some of our data set in Orbiter that actually the placebo-controlled impact of PCI is much greater on focal disease than on diffuse disease, which we might expect, but that it's the physiological pattern of disease that starts to predict outcomes. And that maybe the targets for PCI that are important are going to be to target focal lesions, lesions we really know we can cover with a stent, and then we will have better long-term outcomes versus trying to intervene on diffuse disease. And what's important to remember is that often the diffuseness of the disease is not something you can see on the angiogram. It's the physiology that allows you to evaluate that. So what's in the future? Well, I think there's lots of trials to look out for, and there's going to be much more to come. I think it's going to be really important to integrate both anatomy and physiology to try and work out what we should do, and we can't use physiology as this very blunt tool. I think there is going to be increasingly a place for non-invasive physiological assessment, whether it's CT-FFR or angio-FFR, but trying to guide outcomes without necessarily passing the pressure wire down the lesion. And I think it's going to be really important to think about what the angina threshold is for FFR or IFR, because believe it or not, that has never been studied. And this is a new trial that we're going to start imminently called Orbiter Fire, where we try and work that out. And I think it's going to be really important to work out whether when combining angiography and physiology, we can improve outcomes. And we saw earlier from Professor Sharma that we're going to hear the results from the DEFINE GPS trial in the next couple of years that will tell us whether this makes a difference. I hope that over time we're going to use physiology much more to evaluate our post-PCI result. So again, using it in a much more intelligent way to work out if we can improve outcomes, because it's not enough just to say, oh, well, the physiology was positive, so I've stented this lesion. We need to work out whether we've truly rendered that patient physiologically normal, or at least much better than they were, and whether that has an impact on outcomes. So where are we now? Well, I think that maybe the solution is just not as simple as I thought in the good old days. I think that binary cut points might be what we need in guidelines and in clinical trials, but are unlikely to be the answer. And I think invasive physiology is increasingly going to be used in making a diagnosis, because our patients, of course, need that, but also in defining disease patterns and working out who we should leave alone. And then finally, I think the future is going to involve an integration of both anatomy and physiology, not one or the other, but both together to try and work out if we can improve outcomes. And I'll stop there.